to a child with suspected immune deficiency, when to suspect that one child may have immune deficiency disorder. Immune deficiency can present as primary immune deficiency or PID, which is rare, or can be more commonly secondary immune deficiency. So when to suspect PID, normally in otherwise healthy child, infections can be frequent, especially in early years of life during the development of the immune system. But usually these infections are self-limited and uncomplicated. In between, child is healthy and have normal growth and development. So consider that the child may have secondary cause for recurrent infection first, okay, before consideration of a primary immune deficiency. For example, having recurrent sinopulmonary infections, recurrent sinusitis, pneumonia, or whatever. So you may think of allergic rhinitis, ciliary dysfunction, cystic fibrosis, or recurrent aspiration as a cause for this. Okay, in case of recurrent UTI, consider reflux, basic-ureteric reflux as a cause for this. In case of skin infections, consider presence of atopic eczema. In case of foreign body and indwelling case, this can provide an entry for recurrent infection. So also the use of secondary immune suppressive, medications secondary to malignancy, to malnutrition, to protein losing enteropathy, or protein loss in case of nephrotic syndrome, secondary to diabetes mellitus, especially uncontrolled diabetes mellitus. All these can present with secondary immune deficiency. However, consider primary immune deficiency if the infections are recurrent or persistent, refractory to treatment, if of unusual severity, increasing severity inappropriately, affecting multiple sites, rapid progression into a fulminant and a life-threatening course, frequent use of antibiotics with suboptimal response, presence of opportunistic infections like pneumocystis jirovecii and candida, the other fungal infections, and so on. Presence of failure to thrive, okay, no normal development and growth, and so on. Family history of recurrent infection or early infant disease. Presence of these criteria should raise a suspicion that the child has a primary immune deficiency disorder. We have categories for PID that are all rare. We may have humoral deficiencies in the form of antibody deficiency. We may have cellular deficiency in case of lymphocyte deficiency. Combined deficiencies combining both humoral and cellular deficiency. The defect may be in the phagocytic defect, in the phagocytic cells, or in the innate immunity. We may have complement deficiency. We may have autoinflammatory disorders. So these are the categories. Let's start with the common pattern of infections associated with PID. Recurrent sinopulmonary infections, having recurrent sinusitis, otitis media, pneumonia, bronchiolitis, and so on. These can present with PID. Also chronic diarrhea. Invasive infections like meningitis, osteomyelitis, and the deep organ abscesses. All these should raise suspicion. Presence of opportunistic pathogen like pneumocystis jirovecii and cryptosporidium presenting with watery diarrhea. Also chronic or extensive candidiasis, very important to think about PID, severe or long-lasting warts. Okay, and the molluscum contagiosum. This is severe and extensive molluscum, which is a viral infection. Opportunistic one should raise suspicion also. Recurrent cutaneous or soft tissue abscesses, think of phagocytic defect. Complications of live vaccines. Okay, when we have disseminated tuberculosis after BCG vaccine, when we have polio disease after oral polio vaccine, rotavirus presenting with severe diarrhea, and varicella presenting with severe varicella. So complication of live vaccine should raise suspicion of PID. So PID or primary immune deficiency present with recurrent infections with certain criteria and features, and plus these recurrent infections, we have non-infective manifestations associated. These include autoimmunity. We have mentioned in the beginning of the chapter that we have functions for the immune system. These included the defense against pathogen and also included recognition between self and non-self antigens. This is very important. Also, protection against oncogenic cells, okay, and the development of malignancy. So we would expect that with disorders of primary immune deficiency caused by genetic mutations, associated non-infective manifestations may include autoimmunity, okay, may include hemophagocytosis due to proliferation of hemophagocytic cells presenting with like hemophagocytic lymphohistiocytic syndrome. This syndrome that is systemic one, characterized by clonal expansion of lymphocyte and histiocyte, resulting in hemophagocytosis, ending by aplastic anemia with thrombocytopenia and proliferation of the reticuloendothelial system, presenting with generalized lymphadenopathy, hepatosplenomegaly. So this can be associated feature to the PID. Also, lymphoproliferation and malignancy. Okay, like what occur in autoimmune lymphoproliferative syndrome, and also in common variable immune deficiency that has high risk for lymphoma development. So just to have an idea about that we have non-infective manifestation associated with the PID. Now let's classify and enumerate disorders that are listed under the title PID or primary immune deficiency. These disorders can be in adaptive immunity or in innate immunity. In adaptive immunity, these include more commonly the antibody deficiencies or combined B and T cell defects. Antibody deficiency, this is disorder in the B lymphocytes that produce antibodies. These include these, and they are the more common presenting PIDs, okay, including common variable immune deficiency, selective IgA deficiency, transient hypogammaglobulinemia of infancy, selective IgG subclass deficiency, and X-linked agammaglobulinemia is the worst one, okay. So this antibody deficiency, PID can present as combined P and T cell defects, and under this we have severe combined immune deficiency, the worst one at all, MHC class 1 or class 2 deficiency. These present antigens to the lymphocytes to initiate the adaptive immunity. Also, hyper IgM syndrome is combined B and T cell defect. We will discuss all of these now. Disorders of innate immunity include disorder in phagocytic cells, okay, can include neutropenia or reduction in numbers of neutrophils, and these include congenital neutropenia that is called the Costman disease, or can include Schwarzman-Diamond syndrome, a syndrome that combines neutropenia and immune deficiency with pancreatic insufficiency and some other dysmorphic features. Also, cyclical neutropenia is one of the neutropenias presenting with some immune deficiency manifestations. The disorder in neutrophil can be in its function, neutrophil function defect, okay, with normal numbers. This includes the chronic granulomatous disease and the leukocyte adhesion defect. We may have complement deficiency as one of the innate immunity disorders, either deficiency of any of complements from complement 1 to complement 9. If you remember, we have membrane attack complex formed of C5 to C9, and we had C1 as the initial step in the activation of the classical complement pathway. and we have this C3 as a common pathway for activation of a complement system ending by its effector mechanisms. So deficiency of either of these can present with complement deficiencies and its manifestations. We have properdine deficiency. If you remember, properdine was the initial step in the activation of alternative complement pathway. Okay, so its deficiency will present with complement deficiency manifestations. Also, mannose binding lectin pathway, this is the third one, may be deficient also. And finally, C1 inhibitor, the one protein important as a regulator for complement system activation. Its deficiency would present with continuous complement activation and its manifestations. Starting with the commoner presentation in primary immune deficiency, which is antibody deficiencies. Antibody deficiency can be primary due to genetic mutations or can be secondary. The more common is the secondary causes, including prematurity, for example, as transfer of maternal antibody to the fetus transplacentally is low before 36 weeks of gestation. So preterm birth will be associated with deficiency of antibodies due to a lack of maternal antibody transfer. Excessive losses of antibodies can occur in case of nephrotic syndrome. It's lost in the urine. This called the Bence-Jones protein, Bence-Jones proteins, or the proteins formed of Fab fragments of immunoglobulins lost in the urine. Okay, will end by antibody deficiency. Also, losses can be in stool in case of protein losing enteropathy, losing of excessive amounts of proteins in the stool due to enteropathy will cause antibody deficiency. Severe burns also with protein loss will cause its deficiency. Can be drug induced, can be due to certain infections, can be due to malignancy or autoimmune disorder. These are secondary causes for antibody deficiency. As a primary deficiency due to genetic mutation, antibody deficiency constitutes 65% of all PID, the commoner presentation. We have three main groups for antibody deficiency, including defects in early B cell development or the agammaglobulinemia, or the defect can be in the class switch recombination stage. We have mentioned it, the switch between IgM, the first one to be produced, into the other immunoglobulins can have defect here, or a common variable immune deficiency with deficiency of one or more of the immunoglobulins. These are the three main groups present with antibody deficiency. Early pre-B cell development, the worst one, class switch recombination defect, and common variable immune deficiency. There are other less severe antibody deficiencies which can be insignificant clinically, like selective IgA deficiency can be significant or can be significant. Also IgG subclass deficiency, only deficiency of one of the IgG subclasses. We have 4 subclasses of IgG, and the less severe and the transient entity, which is called the transient hypogammaglobulinemia of infancy. Let's discuss them one by one, starting with the X-linked agammaglobulinemia or Bruton disease or Bruton X-linked agammaglobulinemia. Agammaglobulinemia is caused by arrest in the B cell differentiation at early stage, at the pre-B cell stage in the bone marrow. Okay, so it will result in deficiency of B lymphocyte number and subsequently all classes of antibody or immunoglobulins. In 85% of cases, it has X-linked pattern of inheritance presenting in males early in life. Okay, but remaining 15% of these cases can be autosomal recessive or autosomal dominant and presenting in females also. Here we have genetic mutation in a gene called the Bruton tyrosine kinase. okay, which will cause arrest of B cell proliferation. So the onset, we expect the onset for this disease will be beyond 6 months of age, after waning of the maternal antibodies normally transferred transplacentally, and so a male presenting with recurrent bacterial infections, okay, by encapsulated bacteria specifically, including the pneumococci and the Haemophilus influenza and the meningococci. So the presentation can be with recurrent otitis media, sinusitis, conjunctivitis, pneumonia, empyema, septicemia, and meningitis. Okay, so antibody deficiency will present with recurrent infections with bacteria, specifically encapsulated bacteria. Others include giardiasis, extensive recurrent giardiasis, and enterovirus infections. If you remember the enteroviruses, including the polio and poliovirus that can present with encephalomyelitis, and also Coxsackie viruses. Okay, so this can be a presentation with absence of tonsils and lymph nodes, and GALT, or the gut-associated lymphoid tissue, is characteristic also for the X-linked agammaglobulinemia due to lack of proliferation of these with the deficiency of B lymphocytes. So we expect when doing labs for this male child with recurrent infections, we would encounter that we have low level of all immunoglobulins, including the IgG, IgA, and IgM, with poor or absent antibody response to vaccines. This is a test, okay, to the immune deficiency. When vaccinating an infant, we expect an antibody response occurring within a few weeks. Absence of this antibody response can give a clue for the immune deficiency. Also doing a flow cytometry, okay, to count the cells that carry the cluster of differentiation number 19. Cluster differentiation number 19 identifies a B cell or defines the B cells, okay. So CD19 will be very low, less than 2% of total lymphocyte count due to the arrest in the B cell development, okay. Gene analysis also can define the gene mutation in the Bruton kinase tyrosine gene, diagnosing the condition. So this is a finding in our workup. The management will be in the form of the need for immunoglobulin replacement due to the marked deficiency in immunoglobulins. This should be done prophylactically, not after exposure to infections. Monthly injections, either IV or subcutaneous, targeting to have IgG trough levels of 8 and 9. Okay, so monthly injections with IV or subcutaneous immunoglobulins. Okay, this is the treatment of a choice, okay, with monitoring for this by the IgG trough levels. And by trough level, we mean the level just before the next dose, okay. So we monitor the trough level of IgGs to adjust the immunoglobulin replacement dose. Okay, early initiation of antibiotics is very important before going to a disastrous course. Also, prophylactic antibiotics for lifelong, and avoid live vaccines. Very important to avoid disseminated disease. As a monitoring, we follow the trough IgG levels, and we can do chest X-ray and or CT chest periodically to monitor for the chronic lung disease due to recurrent sinopulmonary infections. Okay, this was the agammaglobulinemia. The second defect, which is called the class switch recombination defect. Here we have a failure of class switch from IgM to IgA and IgG. So we would expect labs will show elevated or normal IgM levels with low levels of both IgG, IgA, and IgE, the other immunoglobulins. Okay, so 70% of cases are caused by genetic defect that will result in CD40 ligand deficiency. This will appear in the flow cytometry. What is CD4 ligand? If this the T helper lymphocyte CD4 carry CD4 antigen, okay, and this is the TCR or the T cell receptor. It has something here called the CD40 ligand. Okay, this is P lymphocyte. Okay, carry the CD40. Normally, for starting class switch between IgM to the other immunoglobulins, we need binding of CD40 ligand with the CD40 here on the B lymphocyte to activate B cell to produce the antibody and to induce class switch. Deficiency of CD40 ligand, which is essentially now it is a T cell defect, okay, will result in lack of this binding stage and lack the class switch stage and the synthesis of immunoglobulins. This is X-linked, okay, disease called the hyper IgM syndrome, where we have defecting binding of CD40 ligand on the activated T cell with CD40 on the B cells, so present with both cellular and humoral immune deficiency, presenting before 2 years of age, with a male having recurrent sinopulmonary infections with encapsulated bacteria, also due to cellular deficiency, opportunistic infections with pneumocystis jirovecii, Cryptosporidium, viruses like cytomegalo and herpes simplex viruses, also mycobacterial disease, all these presenting recurrently in a male child before 2 years of age, with our workup showing raised or normal IgM with low other immunoglobulins, will diagnose the hyper IgM syndrome. T and B cell numbers often normal. We don't have defect in numbers of T or B cells, but defect here. Flow cytometry will diagnose the absence of CD40 ligand expression on activated T cells. Okay, this will be deficient in the flow cytometry. Gene mutation also can be done to diagnose the condition. The management will be as any immune deficiency disorder based on the deficient components of the immune system. We will follow the management protocols. Okay, so cellular deficiency necessitate starting the prophylaxis against pneumocystis jirovecii pneumonia with cotrimoxazole. Okay, also the immune antibody deficiency necessitate periodic immunoglobulin replacement and following the IgG trough levels for adjustment of the dose. For protection against infection, so advising patient he must drink boiled water to guard against infection with waterborne disease like Cryptosporidium, for example. Stool screening for Cryptosporidium, okay, and eradication by azithromycin may be required. Periodic screening for chronic lung disease and the bronchiectasis with chest X-ray and CT chest is very important. In case of severe disease not responding to all these measures, so definitive treatment with hematopoietic stem cell transplantation can be curative. The third common antibody deficiency is a common variable immune deficiency disease. This is the most common form of clinically significant PID. Again, the most common form of clinically significant primary immune deficiency is the common variable immune deficiency, where we have a marked reduction in immunoglobulin levels, at least 2 of the 3 major ones, IgM, IgG, and IgA, with absent specific antibody response to vaccines as characteristic. This is quite common, 1 in 10,000 to 1 in 50,000 population, with wide range of presentations and varying severity present, which usually typically present in adolescent rather than in younger children. Okay, with majority of these are sporadic, not familial. More than 50% of cases have autoimmunity. associated with the common variable immune deficiency in the form of autoimmune cytopenias like autoimmune thrombocytopenia or anemia, pernicious anemia, Crohn's disease, rheumatoid arthritis, autoimmune thyroiditis, and type 1 diabetes. So it's not uncommon for diabetic patients with type 1 diabetes, especially in adolescents and other young adulthood, present with common variable immune deficiency with marked deficiency in 2 or more of the major immunoglobulins. Okay, so with varying presentations depending on the deficient antibodies. There is increased risk of lymphoma in this presentation. So management will be that we have mentioned in the management of low antibodies, including Ig replacement and periodically with following the trough levels, plus early initiation of antibiotics for infections, and the lifelong treatment with prophylactic antibiotics, very important, and other protective measures with good hygiene, and the screening for chronic chest disease, screening for stool infections, okay, and so on. So add here surveillance for autoimmune disease like thyroid function periodically, like type 1 diabetes, and so on. So add surveillance, and in this case, we would need to start steroids and immune suppressive medications. Now the less severe antibody deficiencies. The most common form of PID at all, either significant or not, is the IgA deficiency, selective IgA deficiency, with incidence of 1 per 600 to 1 per 300 populations. This is very common presentation, which is usually asymptomatic, okay, giving no clinically significant disease, but may present with higher incidence of pulmonary and GIT infections. IgA is important for the mucosal immunity. It presents in the mucous membranes. So pulmonary and GIT infections will be more recurrent, okay, with increased risk for atopy, and can be associated with other deficiencies like IgG2 deficiency, also associated with autoimmunity like ulcerative colitis, Crohn's disease, celiac disease, very important. For this, we usually screen for IgA levels during celiac screening, plus the anti-TTG IgA levels. Okay, very common to have IgA deficiency also in this presentation. Okay, there is high risk of malignancy with this disease. So the diagnostic test will be low levels of IgA, but after 4 years of age, very important. Screening for IgA before 4 years, you normally will find it low, maybe. So after 4 years to have this level of low IgA, diagnose selective IgA deficiency with normal other immune globulin level, very important. The clinical significance here may be that this child may have risk for anaphylactic reaction to blood product or immunoglobulins that contain IgA. Okay, but this is extremely rare. This child should be given IgA deficient card. So if he requires immunoglobulin or blood product transfusion, he should receive it IgA deficient. Early use of antibiotics and prophylactic antibiotics may be needed depending on the clinical course of the presentation. The last one of the immunoglobulin deficiency, which is less severe, is the transient hypogammaglobulinemia of infancy, where we have delayed maturation of immunoglobulin production for a known etiology, okay, which resolves spontaneously by 2-3 years of age, with increasing incidence of upper respiratory tract infections, mainly otitis media, during this age period. Okay, having low serum levels of 1 or more of immunoglobulins, less than 2.5 standard deviations for age, on 2 to more occasions. Okay, this benign entity can be distinguished from the more severe entity of X-linked agammaglobulinemia by having normal B cell count. Okay, here we have just immunoglobulin deficiency rather than B cell deficiency that occur in the X-linked agammaglobulinemia, and both these entities present early in life. Okay, in the after or beyond the 6 months of life, after waning of the maternal antibodies, a child presenting with recurrent infections with encapsulated bacteria in the form of otitis media and pneumonia, sinusitis, and so on. So two main entities may be considered. Okay, either X-linked agammaglobulinemia, but this has a marked reduction in B cell numbers, and the other more benign condition, which is the transient hypogammaglobulinemia of infancy, having a normal B cell count, fortunately. If we have major infections are uncommon in this entity unless having very low levels of immunoglobulin. And then, in this case, immunoglobulin replacement may be necessary during this period till spontaneous resolution of the condition. Also, prompt initiation of antibiotics and prophylactic antibiotics